В связи у нас Аднан Сиддики из Соединенных Штатов.
Something
Лечение
already
сложных
been
аневризм.
mentioned. We shift to our next speaker, Adnan Siddiqui, who will talk about treatment of complex
Hello, my
aneurysms.
friends.
Добрый
I
день,
am
уважаемые
sorry
коллеги.
I cannot be there in person. I hope the
Извините,
world would be a
что
better
мы
place where we
должны
can start doing these things
сменить
in person again.
докладчика, и,
Um,
надеюсь, уже в
to my
Hi,
friend
следующий
Adnan.
раз мы будем
Carol and to
встретиться
all the delegates
уже
that are
лицом
there, I
к
hope,
лицу, чтобы
and I wish you would
обсудить
have a very good
наши
Congress.
проблемы.
So Carol asked me to talk about
Михаил
management of complex
попросил меня
intracranial
поговорить о
aneurysms.
лечении сложных
Here are
аневризм.
my disclosures.
Вот здесь мой конфликт интересов.
So
На слайде
certainly the evolution of aneurysm
и
treatment continues. We started with
понимание того, как
clipping and then
лечить
bypass, with or without.
аневризмы,
Then we started with
упражнения,
coiling, and then there was
методы,
balloon-assisted coiling.
привлечались
Then we had a whole slew of different kinds of
скальпинг,
stents that continue to be used,
скульптинга на
including
применении
temporary stenting with Kaminichi.
ассистированных и
And then came the
стент-ассистированных
flow-diverter
методов.
revolution. We have a variety of different devices there. We also have
Сегодня
had
мы используем
intermittently neck
подобные
reconstruction
направляющие
devices. We still have some
устройства
of them available.
для
Many have
восстановления
gone off the market.
шейки,
And the most recent ones are
аневризмы,
now the endosaccular fluid disruptors, starting with the
эндоваскулярные
web, and
прерыватели
more
потока,
recently
такие как
with the lunar
ВЭП и
case and
другие.
the new
Таким
big
образом,
wonder
сегодня у нас в руках
contour, which is
существует
being
огромное
all
количество
employed.
методов, которые можно
So they
использовать,
certainly continue to
но
evolve, but some atoms are just a little
определенно
bit harder
некоторые
and a little bit more
аневризмы
difficult.
настолько
So
сложны
what I
и
like to do
настолько
is think about
сложны с точки
why is the
зрения
aneurysm
лечения. Я в
challenging?
своем
Is it the
докладе попытаюсь
location, difficult
раскрыть,
to
что,
access,
собственно,
absence of
представляет
collaterals,
из
or the
себя
morphology of
вызов
the
лечения
aneurysm,
таких
whether it's fusiform or
аневризм,
broad-necked or
таких как
multilobular,
фузиформные
or branches
аневризмы,
coming off, or
аневризмы
blister,
сложного
or
расположения,
size.
блистерные
I think
аневризмы.
both spectrums are complicated, whether you have a
То
very
есть у нас
small or
наличествует
very
целый
large aneurysm.
спектрум
And certainly other
осложнений, которые мы
features that
должны
add to
принимать во
complexity, whether
внимание,
there's intraluminal
такие
thrombus or prior treatment, prior stents, prior
как
devices,
аневризмы
calcification of the
сложного
vessel wall
расположения,
as well.
аневризмы с
So all these
кальцификацией.
are
И все
difficult
эти
solutions,
факторы
difficult
представляют
aneurysms that
собой
require
сложности с
innovative
точки зрения
solutions.
принятия
And so
решений.
one
Требуют
should always be
разработки
sort of
новых
keen about all
стратегий
the
и
different tools.
новых
You need to think about
решений.
all the
Иногда
toolbox that are available. So what I'd
инновационных
like to do now is just go
решений.
through a whole slew
Что
of
я хотел,
cases
с чего бы хотел
and just kind
начать?
of
Я хотел бы
discuss
представить
my
вам
thought
несколько
process and just take you through it.
сложных
And some of these might be
случаев, которые
controversial and you
представляют
might disagree with
определенную
them. And I
сложность
understand that.
в
But
работе
this is what I did,
я
and this
и
is what
мы
happened.
поговорим о том, чтобы
So it's a
разделать
50-year-old who
из
presents with
случаев
incidental
и
aneurysm.
правильно ли мы
It's a classic
поступили. Вот эта
basilar
50-летняя
fenestration
женщина,
with an associated
классическая
aneurysm. Lots of
фенестрация
different ways of treating
основной
it. I
артерии.
elected to treat it in a sort of a
И
combined
мы
way where
приняли
I preserved both
решение
branches with
выполнить
Elvis, a braided device, and
вентоваскулярное
put some coils in
вмешательство.
between.
Было
Very
использованы
straightforward,
два стента в
and
комбинации с
it resulted in really didn't even have to pack very densely,
микроспиралью.
but
И
complete
видите,
occlusion of
как
the
были
aneurysm and follow-up
установлены
for
вот
multiple
полные
years now. So just
окклюзии аневризмы.
simple wide neck aneurysm made very simple by just protecting
Еще один
both the branches
пример — это аневризма
and occluding the
широкой
intervening segment.
шейки.
Here's a 70-year-old who presented with the family
70-летний
history of aneurysms with
мужчина
intense enhancement of the
который
aneurysm wall.
страдал от большого
Here you
растяжения
can
шейки
see wide
аневризмы.
neck
В данном случае
basilar
было выполнено
75-year-old
девайс
atherosclerosis in
стентирования
both vessels.
склеротированной
And really truly wide neck with
склеротированного
PCAs coming off and SCAs coming off. I still
артерии.
think the best way
Мы
to treat this
использовали
is with bi-stenting. So here are
катетер для
two
того, чтобы
bi-stents
доставить
placed.
стенты.
And
Вместо их
first was Atlas, the other was Enterprise. And then primary
расположения
coiling
мы провели
with complete
микрокатетер
obliteration,
через
showing
стенты. И здесь вы
no
видите
residual
результаты через
in delayed
3
follow-up.
месяца. Следующий
We don't need to stent permanently now. We have this new
случай.
device called the Kaminichi, and
Сегодня
this
у нас
allows us to
нет
sort
необходимости использовать два стента.
treat
Сегодня
the
мы
patient.
используем
This is somebody who comes in who has a bleeding diastasis,
Вот
and so we don't want to put in a
сегодня он
stent
будет
because they have
представлен
multiple GI
здесь
bleeds.
на
And so in this instance,
на слайде.
we
И
deploy through a
данная техника
microcatheter the
демонстрирует,
Kaminichi
что
device. There we have
Каманичи,
access to the aneurysm, and then the Kaminichi device is unsheathed in place after the microcatheter is placed. So I like to have put a coil there, and now the device is being unsheathed. And once it's unsheathed, you can enlarge it and really make it bulge. And then just go ahead and put some coils in until you're really happy with it. Works just like a stent, a braided stent. Then you deflate and you recapture the device. And this is sort of your final result with complete delayed obliteration of this aneurysm. So just a nice, simple way of being able to treat an aneurysm without requirement of a permanent stent. You certainly could say you could do it with balloons. Yes, you can. There was no flow arrest and technically very straightforward. So here's another case of a more complicated aneurysm. So here you can see this is a pica aneurysm with intense enhancement in this person, which is not right at the origin. So it really is some small segment of pica, and then you have this large aneurysm. The problem is the patient also had vertebral osteal disease. So what do we do about this? Is, this is a tandem lesion. So the first thing you do is you do a balloon-mounted stent, address this, and I use a flash osteal balloon. Look at what this balloon does. It's really neat. So you inflate the balloon, and then you have the second balloon to really open up open up the proximal stent so you can get access nicely. Then we put a guide through, and here now we are going to go ahead and put a microcatheter into the aneurysm, a second microcatheter into the pica, and once we have a loop or two of coil in place, then we are deploying an atlas, just trying to make sure that we nail this right at the ostium of the pica, and then we go ahead and put some coils in with abandon until we have a very good result. And this is sort of the final result, which really shows a very good occlusion of the aneurysm. So, just interesting ways of dealing with this. I think there are new devices. There's Baby Leo. There's Sylvester Baby now, which unfortunately is not available in the US. But once they are there, we'll even have more tools in our armamentarium. There's a 60-year-old subarachnoid hemorrhage comes in with this aneurysm with a rupture and gets coiled and recurs, and gets coiled and recurs, and then gets stented with an Elvis stent coil and recurs. And then the goal is to try to put a second stent to convert a Elvis single stent into a Y stent, but we are unable to get access to the contralateral A2. Oh, well, this is challenging. It's getting larger. And what I'm doing here is an interhemispheric approach where I'm exposing both ACAs, and now I'm temporarily clipping the ACAs and opening up the arteries. And once the arteries are open, then I'm suturing the ACAs together, and we continue to suture each individual layer. You can see first we do the inside wall, and then we do the outside wall. And once the whole aneurysm is sutured, we then tighten all the sutures and then restore flow. And then we remove the clips. And there you can see this is a permanent clip in the contralateral A2, which we could not access, being supplied in this distal territory by the ipsilateral elvestented. And this is, and then we go ahead, take the patient in the hybrid suite, go through the ipsilateral A2, and go ahead and coil the fluid. So there is the bypass right here. There's the bypass right here. And the aneurysm vessel, and there's the bypass right there, which showing excellent flow in the distal territory without residual aneurysm. So again, just always think that there are multiple ways of being able to address this. You can keep the head closed ideally, but if needed, you can always open it and address it that way. And so I think that's what's really fun about aneurysm treatment, because of so many different options. So here's another 6-year young man, and so just late teens, presents with the right M1 occlusion, unclear cause, symptomatic. So there it is, M1 occlusion. And so we will go ahead and it doesn't really have the moya type appearance. So we go ahead and we basically present. So this is where he presents the M1 occlusion. And so we go ahead and consider him for a bypass. And this is now my bypass. You can see I have very good territory supply. And there is the bypass you can see on MRA. However, follow-up angiogram shows that he has maybe an aneurysm, the vessel is recanalized. And there's this dissecting aneurysm. And so what do we do in this case? So we go ahead, bring him in, and put a scepter into the aneurysm. There we have it. And then we actually inflate the balloon. There you can see it's being inflated to do a balloon occlusion test with monitoring and with looking at collateralization. And once we look at it with the balloon up, we still see very good collateralization, except in the area where we already have a bypass. So knowing that we have a bypass and the patient tolerated very well, then we go ahead and restore flow, and we just go ahead and occlude this this aneurysm with simply coils and vessel sacrifice. And so this is just a nice, elegant way of being able to treat the whole thing. The microcatheter is removed, and the vessel is gone with this perfusion deficit, which is not a deficit because that is where we have our external bypass, which continues to supply this territory right here. And so there's really no concern because of continued supply from the external carotid, and the patient does very well. Another complicated aneurysm made actually quite simple. Another child presents with acute headache, and when we do the workup, you can see there is a distal P2-3 aneurysm, and so you could do a balloon occlusion test, but it's incredibly straightforward for flow diversion. So once we have our devices there, it really takes no time to deploy a flow diverter across this, and invariably this results in stasis and reconstruction of these vessels. And with newer flow diverters, this is going to get even easier. Here's a more complicated flow diverter case. Previously ruptured aneurysm. Patient had 39-year-old had a rupture, and so this is the original rupture, gets clipped, re-rupture, and this is the aneurysm. The patient comes in, gets coiled, and now comes to me with previously clipped, previously coiled large aneurysm with a true fetal PCOM coming off the base. So in this instance, what do we do? There you can see there's a fetal PCOM that's coming off. The first thing I want to do is I want to preserve the fetal PCOM as best as possible. And so what we do is we just take this, let me show you this back. There's a Simmons 2-type wire. There we go, the wire straightened out. Once we have that, we then, this is a trick that I learned from Jacques Moret for these sort of difficult catheterizations that I cherish. He had come to proctor me for a case, and I thought this was very neat. And then I drop an Elvis through a microcatheter right at the neck of the aneurysm. There is the Elvis that is there right here. So I'm protecting the ostium. And then what I do is I deploy a flow diverter and I jail a microcatheter in the aneurysm. So the microcatheter in blue, the flow diverter in red, and then we go ahead and deploy a flow diverter across the neck of the aneurysm. Now we are left with stasis And there is the Elvis, which allows persistence of flow within the pica, and then we go ahead and coil this aneurysm, and again, complete obliteration and follow-up. This is immediate result of the preservation of the fetal precom. And so really just novel ways of combining different strategies. Again, let's go back to difficult made easy. I think this is a nice case of a web device. There you can see this would be a Y stent or a clip, but with web, it is just made incredibly easy. You catheterize, you put the microcatheter there, and then you bring the web, and sometimes you have to reposition once or twice, but that's it. It just lands in there. You get the sizing right. There you can see again, bringing the device in and expanding it, and there it pops right into place. Once, my definition of a good web case is when the aneurysm looks like a web. This looks like a web. I think it's a perfect case for a web. And again, complete occlusion and delayed follow-up. Another iteration of endosaccular flow disruption, difficult made easy, no need for Y stenting, is the contour device. And I quickly show you a couple of cases here. The patient who comes in with incidentally discovered MC bifurcation aneurysm. This is complicated. You could T stent, you could Y stent, you could do a lot of different things. But with contour, all you need to do is deliver microcatheter into the aneurysm and then deliver the device. And the device just deploys, pops it right there. And once you have it in place, you immediately have flow arrest. The most important thing is to make sure you right-size the device. Don't undersize, because if you undersize, you're going to have a problem. Let's finish with something really complicated, and polybasilar aneurysms. This is a case I did recently with triple therapies, and patient who's been falling forever, got shunted, hydrocephalus, aneurysm is continued despite maximum medical therapy, induced antiplatelets, maximum statin. And this is what the aneurysm sort of looks like on CTA with both codominant vertebrals and the diameter of the aneurysm. This is again, this is vessel enhancement. So you can see the amount of vessel enhancement and almost as an inflammatory change that is clearly occurring with some concern for some initiation of some thrombus as well. And here's the angiography of one side, and this is the other side, which shows sort of ectasia of the distal vertebrals on both sides, and then into the distal PCAs on both sides. So this is sort of the 3D rendering from one side, and so we use it has gone from 6 millimeters in 2012 to 12 millimeters in 2023. Young woman. And so more and more I feel that we should probably treat these sooner. But she was lost to follow-up, so she comes back with a doubling of the size. We do a lot of planning with the software to really figure out how we're going to do devices. And then what we actually do is we do parallel systems of both vertebrals to deploy the device. And so this is the final result. The patient on triple therapy, so Aspen, Prasugrel, and Eliquis. So this is one series of devices. The second series of devices, we had trouble with one of the pipelines, so we ended up using a Fred instead. Here's rotational. Again, you can see the two channels have already started separating acutely during the procedure, immediately after the procedure. And this is sort of rotational to show you how these two devices, starting with the PCA, the way we did this was we started with proximal and distal and recreated two pipelines in parallel for treatment. So I think that certainly is an interesting way of being able to deal with this disease. And With that, I'd like to end by talking about the complexity of aneurysms can be anything from morphology, location,
я хотел бы ответить, что
comorbid conditions,
сложность лечения той или иной
but
аневризмы
keeping a cool chest available,
нивелирована как с точки
thinking,
зрения
being
морфологии, так с точки
innovative
зрения
and being flexible and being creative
так с точки
allows us
зрения
to treat the
наличия
vast
тандемных
majority of these
поражений
aneurysm
через
diseases
использование
effectively. Certainly,
инновационных
not
устройств
without risk, not without
последнего
complications, not without adverse events.
через
My
правильное
hope is that we continue to do things better and get stronger and better. And I thank you very much for your attention. And I wish you all a wonderful Congress.
случаев.
Thank you very
Большое
much.
спасибо за ваше внимание.